A woman arrived at the emergency room with severe abdominal pain. The attending physician took one look at her and, according to witnesses, made an assumption. He reportedly told nurses she was probably drug-seeking and recommended sending her home with ibuprofen. The woman tried to explain her symptoms. She mentioned her medical history, but according to multiple accounts, the doctor dismissed her concerns and walked away. What the doctor didn't know was that the woman he just refused to treat was Dr. Michelle Crawford, a renowned cardiac surgeon who also happened to own a 40% stake in the hospital where he worked. She wasn't there as a doctor that day. She was there as a patient in genuine medical distress. What happened in the next hour sparked a national conversation about implicit bias in healthcare, the treatment disparities faced by Black patients, and what happens when those in power experience the very discrimination they're supposed to prevent. Before we examine this controversial incident, hit that like button and subscribe for more commentary on important issues affecting healthcare and equality. Now let's look at what reportedly happened that day. Who is Dr. Michelle Crawford? According to public records and medical directories, Dr. Michelle Crawford was a 52-year-old cardiac surgeon with over 25 years of experience. Medical journals show she had published numerous research papers and was considered an expert in minimally invasive heart procedures. Healthcare industry sources indicate that Dr. Crawford had built an impressive career despite facing obstacles that many of her colleagues never encountered. As a Black woman in a field dominated by white men, several profiles noted, she had worked twice as hard to earn half the recognition. Beyond her medical practice, business records show that Dr. Crawford had invested in Memorial Grace Hospital 10 years earlier. Along with two other physicians, she had purchased a significant ownership stake during the hospital's financial restructuring. Her investment had helped save the hospital from closure, according to local news reports from that time. Colleagues who spoke to media outlets described Dr. Crawford as brilliant, demanding, and deeply committed to patient care. Some noted that she had advocated within the hospital for protocols to address racial disparities in treatment. Ironically, the very issue she would soon experience firsthand. The doctor, Dr. James Patterson, the physician involved in the incident, was identified in reports as Dr. James Patterson, a 38-year-old emergency medicine specialist who had worked at Memorial Grace Hospital for 3 years. His employment records, according to sources, showed no previous disciplinary actions. However, some nurses who worked with Dr. Patterson told reporters, on condition of anonymity, that they had noticed patterns in his treatment of patients. Several claimed he seemed to spend less time with Black patients and was quicker to dismiss their complaints of pain. Others said they hadn't noticed any issues with his care. Medical experts interviewed about the incident pointed out that implicit bias in healthcare is well documented in research. Studies have shown, they noted, that Black patients are often undertreated for pain. Their symptoms are more frequently dismissed, and they receive lower quality care overall compared to white patients with identical conditions. These experts emphasized that such bias often operates unconsciously. Physicians may genuinely believe they treat all patients equally while statistical evidence shows otherwise. This makes the problem particularly difficult to address, several commentators noted. The day of the incident, according to reports, Dr. Crawford had been experiencing severe abdominal pain for several hours. As a physician herself, she initially tried to self-diagnose and manage the pain. But when symptoms worsened and she developed a fever, she drove herself to the emergency room at Memorial Grace Hospital. She arrived, according to witness accounts, in casual clothes, jeans, and a sweatshirt. She wasn't wearing anything that identified her as a doctor or hospital owner. To the ER staff who didn't know her personally, she appeared to be just another patient. Several people who were in the waiting room that day later told reporters that Dr. Crawford looked uncomfortable and in pain. She was holding her abdomen and appeared to be having difficulty sitting still. The wait time, they noted, was approximately 45 minutes before she was taken to an examination room. Once in the exam room, according to accounts that later emerged, Dr. Crawford provided her medical history to the nurse. She explained her symptoms clearly and mentioned that she was concerned about possible appendicitis or an ovarian issue. The nurse documented this information in the medical record. When Dr. Patterson entered the room, what happened next would become a matter of significant dispute and debate. The healthcare disparity context, medical researchers and civil rights advocates noted that Dr. Crawford's experience if accounts were accurate, fit a well-documented pattern. The American Medical Association and other organizations have acknowledged that racial bias in healthcare leads to worse outcomes for Black patients. Statistics compiled by healthcare researchers show that Black women, in particular, face shocking disparities. They are, according to CDC data, 3 to 4 times more likely to die from pregnancy-related complications than white women. They report higher rates of having their pain dismissed by medical providers, and they experience longer wait times and less thorough examinations. These disparities exist, researchers noted, even when controlling for insurance status, education level, and income. A Black woman with a medical degree and substantial wealth, the data suggested, could still face discrimination in healthcare settings. Some medical ethicists argued that this context was crucial for understanding the incident. Others cautioned against assuming discrimination without clear evidence. The debate highlighted the complex challenges of identifying and addressing implicit bias. The initial interaction, according to Dr. Crawford's later account to investigators, Dr. Patterson entered the examination room and immediately seemed dismissive. She stated that he barely looked at her medical chart before addressing her. "He asked what brought me in," Dr. Crawford told reporters in a subsequent interview. "I explained my symptoms, the severe pain, the fever, the location, and duration. I told him I'm a physician and I'm concerned about appendicitis or a possible ovarian torsion." Dr. Crawford's account continued. "He looked skeptical. He asked if I had taken anything for the pain. When I said I'd taken over-the-counter medication, he said, 'That should be sufficient.' I tried to explain that the pain was getting worse, not better. He cut me off." Witnesses outside the examination room, including 2 nurses, later told hospital investigators they heard raised voices. One nurse reported hearing Dr. Crawford repeatedly trying to explain her symptoms, while Dr. Patterson's responses seemed curt. According to the nurses' statements, they heard Dr. Patterson say something about pain medication seekers being common in the ER. One nurse said she felt uncomfortable with how quickly Dr. Patterson seemed ready to discharge the patient without a thorough examination. The escalation Dr. Crawford's account of what happened next painted a picture of increasing frustration. "I asked him to order a CT scan or at least do a proper physical examination," she said. "He told me that wasn't necessary and that I should go home and follow up with my primary care physician if symptoms continued." She reported that, when she insisted something was seriously wrong, Dr. Patterson's demeanor became what she described as condescending. "He told me, 'Ma'am, I'm the doctor here. I know what tests are necessary.'" The irony was painful, literally and figuratively. At this point, according to multiple accounts, Dr. Crawford made a decision. She pulled out her hospital ID badge, which identified her as both a physician and a member of the hospital's board of directors. "I showed him my credentials," she later recounted. "I told him, 'I'm Dr. Michelle Crawford. I'm a cardiac surgeon. I'm on the board of this hospital. And I'm telling you as a patient and as a physician that something is seriously wrong.'" The moment of realization, witnesses reported that Dr. Patterson's expression changed dramatically when he saw the ID badge. One nurse who was present said his face went pale. Another described him as appearing shocked and then terrified. According to Dr. Crawford's account, Dr. Patterson's entire demeanor shifted instantly. "Suddenly, he was willing to order every test I had originally requested," she said. "The CT scan, blood work, ultrasound, everything. The change was so dramatic it was almost comical, except it wasn't funny at all." Dr. Crawford told investigators she had a realization in that moment. "If I hadn't been a doctor, if I hadn't been a board member, if I hadn't had that ID badge, I would have been sent home. And given what they found, that could have killed me." The medical findings, the CT scan, and subsequent tests revealed, according to medical records, that Dr. Crawford had a ruptured ovarian cyst with internal bleeding. The condition required immediate surgical intervention. Left untreated, it could have led to sepsis or hemorrhage. Dr. Crawford was admitted for emergency surgery. A different surgeon performed the procedure, which was successful. But the medical team noted in their report that any further delay in treatment could have had serious consequences. The irony was not lost on observers. Dr. Crawford, an accomplished surgeon, had nearly been denied life-saving care at her own hospital. The immediate aftermath in the ER following the revelation of Dr. Crawford's identity. Several staff members reported that Dr. Patterson appeared extremely distressed. He reportedly tried to apologize repeatedly. But Dr. Crawford, according to witnesses, was too focused on her pain and the need for treatment to engage with his apologies. One nurse told investigators that she heard Dr. Patterson say, "I didn't know who you were," to which Dr. Crawford reportedly replied, "That's exactly the problem. My identity shouldn't matter. Every patient deserves thorough care." Hospital administrators were notified of the incident while Dr. Crawford was in surgery. By all accounts, they understood immediately the severity of what had occurred, both medically and institutionally. The story emerges the incident remained private for several weeks while Dr. Crawford recovered from surgery. However, according to sources close to the situation, word began to spread within the hospital. Staff members discussed what had happened. Some were shocked. Others said they weren't surprised. When the story eventually leaked to local media, the response was immediate and intense. News outlets across the country picked up the story. Medical organizations issued statements. Civil rights groups demanded investigations. The narrative struck a chord because, as many commentators noted, it perfectly illustrated systemic issues in healthcare. Here was a wealthy, educated, accomplished black woman who nearly died because a doctor made assumptions based on her appearance. The medical community responds. Physicians across the country weighed in on the incident. Many expressed dismay and acknowledged that implicit bias in medicine was a real and dangerous problem. The American Medical Association released a statement noting that healthcare disparities based on race are well documented and unacceptable. This incident highlights the urgent need for continued training and systemic reforms. Some doctors, however, defended Dr. Patterson, arguing that physicians face tremendous pressure and must make quick decisions. They contended that without knowing all the details of the interaction, it was unfair to assume racial bias was a factor. This response prompted sharp criticism from others who argued that defending such clear disparities in care perpetuated the problem. The debate within the medical community became heated and revealing. Civil rights organizations seized on the case as evidence of pervasive discrimination in healthcare. Several national advocacy groups issued statements calling for systemic reforms. This incident proves that racism in healthcare isn't about individual bad actors. One organization's statement read, "It's about deep-seated biases that affect care even when patients are doctors themselves. If Dr. Crawford can be dismissed and nearly die, what chance do ordinary black patients have?" Some activists organized protests at the hospital, demanding not just disciplinary action against Dr. Patterson, but comprehensive changes to how the hospital addressed racial disparities in care. The social media reaction, the story trended on multiple social media platforms. The hashtag #BelieveBlackWomen gained renewed attention, with many users sharing their own stories of medical discrimination. Black women in particular shared experiences of having their pain dismissed, their symptoms minimized, and their medical knowledge questioned even when they were healthcare professionals themselves. Some users noted the bitter irony that Dr. Crawford owned part of the hospital where she was mistreated. "Even wealth and status can't protect black women from medical racism," one viral tweet stated. However, others cautioned against rushing to judgment without knowing all the facts. Some argued that one bad interaction didn't prove systemic racism, sparking intense debates in comment sections. The hospital's response, Memorial Grace Hospital, issued a carefully worded statement acknowledging that an incident occurred involving a lapse in the standard of care we expect. They announced an internal investigation and said they were committed to ensuring all patients receive excellent, unbiased care. Critics noted that the statement didn't mention race or acknowledge the specific concerns about discrimination. This perceived avoidance became its own point of controversy. The hospital board, of which Dr. Crawford was a member, held an emergency meeting. According to sources, the discussions were intense. Dr. Crawford reportedly argued for major policy changes, while some board members wanted to treat the incident as an isolated occurrence. The broader debate the incident sparked broader conversations about healthcare equity. News programs featured panels of experts discussing implicit bias. Medical schools reported increased interest in training around cultural competency and anti-racism. Some commentators argued that the incident proved the need for more diversity in medicine. Others focused on the need for better systems to identify and address bias when it occurs. A few voices suggested that the focus on one dramatic incident, while understandable, might overshadow the countless similar cases that never made headlines because the patients weren't wealthy or well-connected. The investigation Memorial Grace Hospital conducted a formal investigation into the incident. According to reports, investigators interviewed Dr. Patterson, Dr. Crawford, nursing staff who were present, and other patients who were in the ER that day. The investigation report, portions of which were later leaked to media, found that Dr. Patterson had failed to meet standards of care in his treatment of Dr. Crawford. The report noted that he had not performed a physical examination, had dismissed the patient's stated concerns, and had made treatment decisions based on assumptions rather than medical evidence. However, the report stopped short of explicitly finding racial bias, stating that, while implicit bias may have been a factor, it is difficult to prove definitively what motivated the physician's decisions. This conclusion disappointed civil rights advocates, who argued it represented an unwillingness to acknowledge obvious discrimination. Hospital administrators defended the report as thorough and fair. Consequences for Dr. Patterson. Dr. Patterson was suspended for 30 days without pay and required to complete extensive training on implicit bias, cultural competency, and proper patient assessment protocols. He was also placed on probation for 1 year, meaning any further issues would result in termination. Some observers felt these consequences were too lenient. Others argued they were appropriate for a first offense. The debate reflected broader disagreements about accountability in cases of potential discrimination. Dr. Patterson issued a public apology, stating, "I failed to provide the thorough care that every patient deserves. I am deeply sorry for my actions and committed to learning from this incident. I am grateful Dr. Crawford is recovering, and I accept full responsibility for my shortcomings." Critics noted that the apology didn't specifically acknowledge racial bias, while supporters said it was appropriately focused on the medical failures rather than motives that couldn't be proven. Dr. Crawford's actions. Dr. Crawford used her position and platform to push for systemic changes. She advocated for, and the hospital board ultimately approved, several new policies. Mandatory implicit bias training for all medical staff, to be repeated annually. The establishment of a patient advocacy office where complaints about discriminatory treatment could be filed and investigated. Regular audits of patient care data to identify potential disparities in treatment based on race, gender, or other factors. A new protocol requiring second opinions when patients express serious concerns that are being dismissed. Some healthcare policy experts praised these changes as meaningful steps forward. Others questioned whether training and policies could truly change deep-seated biases. The personal impact. In interviews months after the incident, Dr. Crawford spoke about how the experience changed her. "I thought I understood healthcare disparities intellectually," she said. "I'd read the research, seen the statistics. But experiencing it yourself, feeling that helplessness when someone with power over your health doesn't believe you, that's different." She noted that the experience had made her a more empathetic physician. "When patients tell me something is wrong, I believe them now in a way I didn't fully before. I don't care what the tests say initially. I don't care if it doesn't fit the textbook presentation. If a patient says they're in crisis, I listen." Dr. Crawford also acknowledged the privilege that ultimately saved her life. "I had credentials to flash. I had status to invoke. Most patients don't have that. How many people have been sent home from ERS and suffered because they didn't have my advantages? That thought haunts me." The broader impact on healthcare. The incident contributed to growing momentum for addressing healthcare disparities. Medical schools reported increased focus on teaching about implicit bias. Several states introduced legislation requiring cultural competency training for licensed healthcare providers. However, progress remained uneven. Some hospitals embraced comprehensive reforms, while others made only minimal changes. The medical establishment's response to discrimination remained a source of frustration for many advocates. Healthcare researchers continued to document persistent disparities. Studies showed that while awareness of the problem had increased, outcomes for Black patients hadn't improved as much as hoped. The gap between recognition and action remained wide. What changed, and what didn't? 3 years after the incident, assessments of its impact were mixed. Memorial Grace Hospital had implemented its promised reforms and reported some improvements in patient satisfaction scores among minority patients. Dr. Patterson completed his training and probation and remained employed at the hospital. though some staff members and patients remained uncomfortable with his continued presence. Dr. Crawford continued to practice medicine and serve on the hospital board, using her experience to advocate for change. She became a sought-after speaker on healthcare equity and implicit bias. But many observers noted that the fundamental problems persisted. Black women still faced higher maternal mortality rates. Pain management disparities continued. Complaints about dismissive treatment remained common. Some activists argued that the incident had changed little, because it was treated as an isolated case of one doctor's failure, rather than evidence of systemic problems requiring systemic solutions. The lessons for those following the story: several lessons emerged that commentators and advocates emphasized. First, many noted that credentials and status don't protect against discrimination. If a successful surgeon and hospital owner could nearly die from biased care, anyone could. Second, observers emphasized that implicit bias operates even among well-intentioned professionals. Dr. Patterson apparently had no history of overt racism, yet his treatment of Dr. Crawford showed how assumptions based on race could literally kill. Third, advocates stressed that individual training and accountability, while important, aren't sufficient. Systemic problems require systemic solutions: better protocols, more diverse medical staffing, stronger oversight mechanisms. Fourth, some commentators noted that the incident highlighted the importance of patient advocacy. Dr. Crawford's insistence that something was wrong and her ability to eventually make doctors listen saved her life. But most patients lack that power. Finally, many observers reflected on what the incident revealed about American healthcare. The fact that such clear disparities exist in a wealthy, technologically advanced medical system suggested deep cultural and institutional failures that training alone couldn't fix. Moving forward years after the incident, the conversation it sparked continued. Dr. Crawford remained a prominent voice for healthcare equity. Dr. Patterson continued practicing, though his reputation carried the permanent mark of the incident. Memorial Grace Hospital pointed to its reforms as evidence of commitment to change. Critics argued the reforms didn't go far enough and weren't being enforced rigorously. The broader healthcare system continued to grapple with documented disparities. Some institutions made genuine efforts at reform, while others resisted acknowledging problems. Perhaps most significantly, the story became part of a larger narrative about how bias operates in supposedly objective, scientific fields like medicine. It served as a concrete example in training sessions, a case study in medical ethics classes, and a rallying point for advocates demanding change. Whether that awareness would translate into measurably better outcomes for Black patients remained an open question. But advocates emphasized that awareness was at least a necessary first step, even if far from sufficient. If this commentary made you think about important issues like healthcare equity and implicit bias, hit that like button and subscribe for more in-depth analysis of stories that matter. Share your thoughts in the comments. How can we make healthcare more equitable? What reforms would actually work? Thanks for watching, and remember, everyone deserves to be heard, believed, and cared for regardless of their race, status, or background. See you in the next video.